In 2016, the UN General Assembly, all of our member states, committed to reducing TB deaths among people living with HIV by 75% by 2020, compared to a 2010 baseline. So by the end of 2017, we'd achieved about 42% reduction, but that's not enough. And so UNAIDS and partners, we are all advocating strongly for countries to really scale up preventive treatment. During the UN high-level meeting on TB in 2018, member states again committed more specifically to providing TB preventive treatment to at least 30 million people by 2022. And that includes not only 4 million children under the age of 5, but also 6 million people living with HIV. However, we know we're behind. According to data collected by UNAIDS and WHO, globally, we have only reached 1.76 million people living with HIV with preventive treatment for TB by 2018. Now, that's a huge jump from where we're at in 2017, so we're making progress. But you know, we're not there yet, as we've been talking about all day. Now, this might be an issue of data collection, but I think it also has to do with program rollout, and I think our panelists will shed some light on that as well. Data-wise, only 15 of the 30 high TB HIV burden countries reported data on TB preventive treatment among people living with HIV. And the coverage that was reported ranged from about 1% in Eswatini to about 53% in South Africa. So how much is measurement, how much is program progress? Let's unpack that a little bit. So we're going to take a little interesting format. We're going to do 3 rounds of questions, looking at global perspectives, looking at national perspectives, and then really diving into what sort of innovation in research, in program delivery, in policies might be needed to really advance. So with that, maybe I will start with Sharonann and say, from a global perspective, what will it take to build political engagement globally and nationally for preventive therapy?
We have countries that have signed the dotted line in terms of reaching more people with TB preventive therapy, but frankly, that means nothing unless it actually happens. So what needs to happen, and if we're going to have real accountability, is to have country-specific metrics. So that, because right now, based on the UNHLM target, if everyone is responsible, then no one is accountable. And what's helpful is Stop TB Partnership, they made country-by-country targets based on the UNHLM that's available on their website. So if we can, stop printing beautiful, agendas, stop having the fancy lunches, we could have had a box lunch, that would have been fine, and start funding activists as much as possible so that the activists can push for TPT and the PEPFAR COPs, activists can push for TPT and the Global Fund proposals, and in their national strategic plans. And we know where we need to push the most are HIV projects. I think we can all agree that's where we hope to have the most success. And it's a damn shame that given the attention that is toward HIV community-based testing, which is fantastic, and the rollout of HIV self-testing, that we're not able to ride those tailwinds, not only in terms of the attention and the money, but where people are going. People are going house to house. People are going to the community level. Why we can't have TB Lamb there? Why we can't have a community platform to provide 3HP or Q-tip in terms of having a community-based dispensing? That's where we need to go now. Also, frankly, if UNAIDS, so Shannon, we don't have anyone that has yet convened the largest potential procurers of 3HP in order to negotiate down some of the prices and attract more of the generic suppliers. But also, UNAIDS, the donors, and national governments have got to be strong in their resistance to Sanofis patents. So get this, do you mind, Shannon? So, Sanofi, they are making 3HP. They have the only pre-qualified product. The problem is that in lieu of generic competition, they have the monopoly. That's why they're able to charge $45, although obviously not many people are buying. Now, Sanofi did not invent the 2 drugs for 3HP. We all know, what year was INH invented? Anybody? Yes, you're exactly right, 1952. And rifapentine, when? 1960s. And yet, Sanofi has filed for patents for their fixed-dose combination in 70 countries. So as much as we want the pediatric FTC, both from Sanofi and the generics. As much as we want the fixed-dose combination for adults, it will be harder with Sanofi jumping country to country and essentially locking out the generics and for a preference for their product. This is where, on this side, we have to be smart in terms of rejecting that and negotiating more strongly. Thanks.
Thanks, and I think we'll have time to come back a little bit more for political issues on new developments as we go on. Maybe I'll go to Wim, because I think what I wanted to ask you about is building a little bit off of Sharonann. What should accountability look like? What's the real global accountability framework we need, and what is it going to take to get there?
So, thank you, Sharonann. Well, it was mentioned this morning already, if it's not measured, it's not happening. So, and also important, like Suvanand said, that the targets are a floor, they're a floor, they're not a ceiling. So this is really the minimum, and we need very good reporting to follow that up. But I think accountability is very necessary on the country level as well, and even on a subnational level. If you look at even at the city level, if you look at the Fast Track Cities initiative, that is working well. That should also incorporate TB very well. But so first of all, governments must make sure that the international standards, that they are translated into national guidelines and that they keep up with the latest science, so they need to be updated regularly. And then beyond setting the national guidelines, government should also make plans and roadmaps for addressing these TB and HIV co-infections. And frankly, where governments don't do this, communities can also lead on this. We've seen, for instance, in the US, on the end of the epidemic roadmaps, that communities can create such a roadmap that are then adopted by the local governments. And so it can also come bottom up, not just bottom down.
Go ahead and skip over to Cordelia. And Cordelia is an HIV program manager and really in charge of all the HIV program in your country. How can we persuade AIDS community in general and HIV program practitioners to fully embrace TPT? What are the barriers we have to overcome there, and how do we do it?
Thank you very much. I don't know if the word would be persuading the HIV programs. As I was just thinking through the question, I think time has come that the HIV programs, as we are moving towards epidemic control and focusing on efficiencies in care to ensure that we are no longer having reduced mortality in HIV as one of the key elements in epidemic control. I think the writing is really on the wall for the HIV programs to get up and begin to embrace the whole component around TB, and in particular TB preventive therapy. So, but because that has been a major gap between the two programs, HIV and TB, when we say persuasion, I would want to use the word probably meaningful engagement between the two programs, and I'll just give an example of what is happening in Uganda. And over years, there's been all those barriers, right from the financial bottlenecks. How do we have financing for TB, financing for HIV? Which finances go to the TB program? Which ones go to HIV? And there's always been that. But with a meaningful engagement at our country level, we are beginning to see that the bottlenecks that have got to be overcome is people sitting together and having a more coordination framework. One, to sit at the same table and budget for what is going to be covered by each of the programs, and having agreement on what is going to be done. In this case for Uganda, we sat with the National TB Leprosy Program and the HIV and the AIDS Control Program in determining who brings, in terms of the donor funds and the government of Uganda funds, what goes to the AIDS Control Program, what goes to TB, but also being mindful of the fact that IPT or TB preventive therapy really belongs to the HIV clinics. Two, there's been the engagement with civil society that has to happen. So civil society and the networks of people living with HIV, and focusing on the implementation by the peer leaders. And these are found within the HIV clinics. So as we've come together as the two programs, there's been that meaningful engagement of PL HIV, as well as the civil society and the peers to be engaged in health education, in literacy and information around TPT. So for me, it's really about this. We can go and talk about meaningful engagement in the different areas, right from training, right from financing, commodities, but between the two programs. So sitting on the same table, coordinating at that level. And in Uganda, we have seen really successful results from that engagement and coordination of the two programs that has resulted in big numbers of people being put on IPT just from that engagement.
Great. So we hear meaningful engagement and really working together, and we heard a little bit from Wim about updating guidance and policies and keeping track so that we can really be accountable for the results we need. So, Dr. Vindi, you've been involved in revising and updating global indicators for TB, HIV, including TB preventive therapy. So how can better monitoring really help us reach those those global targets and hopefully bring meaningful engagement to fruition? And to what extent do you think more countries are implementing preventive therapy but not recording it versus they don't have the right indicators that are going to motivate the programs to come together and implement?
Thank you. I actually will just mention that we are at WHO, along with UNAIDS and other partners, updating our SI guidelines, WHO SI guidelines. And we are going through a process of looking at our TB HIV indicators, including the TPT indicator. And as we've mentioned, only 15 of 30, as you've mentioned, top high burden countries, TB HIV burden countries, reported on this indicator. We're not, speaking of monitoring and reporting, we're not quite sure what the reason for that is. We know that there are policy gaps. We know that there are, reporting gaps, and there are quality of service gaps, et cetera. The component of this that is related to indicators is difficult to unpack. We did hear in one country at a meeting that I think Cordelia and I were at recently that providers were only providing IPT, in that country it was IPT, to new enrollees in HIV care, because that was the global indicator that we reported on. However, the global indicator was selected for a different purpose. It wasn't to say that was what the policy, the programmatic service delivery policy was. It was to track trends in a scale up of IPT. And yet our ARV guidelines and our TB, LTBI guidelines all said that people living with HIV, all people with HIV were eligible for IPT or TPT. So there can be some indicators are important, and people can implement sometimes just to report on an indicator. So with that in mind, we are planning to expand this indicator to all living with HIV who are eligible. And we understand that information systems may not always be up to speed, so we hope that countries can report to the Global TB Program and to UNAIDS and us and tell us what challenges they're facing so we can understand better and how we can help. We also we're looking at adding a completion component to this, because we know that it's really the TPT completion that is ultimately important for the benefit to the patient and to the community. We also understand that information systems need to be strengthened and monitoring systems need to be strengthened. I think we heard the challenges there. Thanks.
Okay, great, thanks. Let's go to Dr. Patrick next. And I think turning to you and thinking about the national level and your role as, in charge of the TB program. There's a lot of resistance among clinicians in a lot of countries to really start prescribing TPT. So how do you change this? What are you doing in Zambia? What do you think is needed to help push clinicians out of their comfort zone into a new comfort zone and really get on board with TPT?
Thank you very much. I'll share the Zambian perspective of TPT and how clinicians actually see it. I want to mention that TPT has been in Zambia for a long time. And I think the uptake was affected by clinicians, their opinion as well as their perspective of TPT. So I think one of the things that was the biggest barrier was the way the guidelines were initially crafted. One of the things that most senior clinicians earlier thought that TPT actually needed to include other risk populations, and this also included patients who were already on ART. But the initial guidelines only looked at patients who were starting ART, so that in itself affected how clinicians looked at TPT, and they thought that that was not quite inclusive, and that affected the uptake. Then also there were a number of myths about TPT. Some clinicians earlier thought that there was putting some patients on TPT would actually bring resistance to isoniazid and many other things. So I think what has helped break through those barriers are the myth busters that have been provided by CDC as well as USAID. That in itself has actually unlocked the barriers that was there. So I think for us as a country, one of the initiatives that we took, we did realize that TPT was very cardinal for us to reduce the TB incidence. And we did realize from the onset that we cannot do this all by ourselves. We needed the HIV program on board to buy into the vision. And what we did was we did a lot of engagement with the stakeholders, and these were the HIV clinicians, HIV program itself, before we could engage larger groups. And also, we took an initiative also of engaging opinion makers. Some of the academicians in universities were brought on board and brought to speed of where we were. And these became our voices. They spoke largely, and we got the buy-in in of most people through this initiative of engaging opinion makers. So those are the things I think we did largely to get us to speed to where we are. Then also I think we also got the HIV program to look at their own data, to say first of all I think look at your own data. And they looked at their own data and they found that TB was the disease that was causing a lot of morbidity among people living with HIV. And second, it was the leading cause of mortality. And I think those unlocked the barriers that were there before.
Great, thanks. So meaningful engagement between the HIV and TB programs, again, to use Cordelia's term too, recruitment of provider influencer superstars to really get people excited and make them feel comfortable with this. And then Cordelia mentioned, as part of that meaningful engagement of community. So maybe WIM, talking about communities, what does it mean for them to be at the center of TPT planning, and what needs to be done to really create a demand? I don't see people marching in the streets yet demanding TPT. I would be really happy to see that, but that's sort of a hard list. So what do you think needs to be done?
I think it's been said during the day a couple of times, and we've heard the great examples of Impact for TB, which is doing great community engagement work for the moment. So you need to start with treatment literacy. You have to give them empowerment to the communities, and not just during the implementation of the project or afterwards, but also from the beginning, from day one. there are community representatives who can sit at a table and who can translate the needs from the grassroots communities at the table even before the grant is written. You know, and that is often forgotten. We include them meaningfully afterwards, but not when it really counts as very often. But so that there are exceptions of projects who do that very well, but it's all about education, education, education. And then as soon as the people understand why certain interventions work, and if they work, they will ask their governments to have them either through domestic funding or have them written into the plans for the concept plan. So, but in HIV we've done years and decades of treatment literacy, and it pays off. And in TB we just scratched the surface, really.
Great, thanks. And I think sometimes these days when we say treatment literacy, people who haven't done it think it's just education. But I think you're talking about really empowering clients to ask for what they need by knowing what's available and what they deserve.
But if I may, just veering a little bit off topic, I hear a lot of inclusion of civil society and the communities, but the fact is that in a lot of our countries, the civil society space is shrinking, and fastly, especially in the BRICS countries. You know, when you look at the harassment that is happening with leading lawyers like Anand Grover in India, who has been crucial for the HIV epidemic and how it's helping access improve a lot through generics, he is now under attack by the governments, and we see that in different countries, especially in the BRICS countries. So, as global health actors, researchers, civil society, policymakers, we can't turn a blind eye on the human rights abuses that are happening. So, not just because we want a photo op with a prime minister or a president because he promised to end TB in 1 or 2 years. So, we have a responsibility, I believe, as well.
Great, thanks. Maybe over to Sharonann, and to keep building on that, communities. What additional supports do people living with HIV and other people in need of TPT need to be successful to increase demand, to increase uptake and treatment completion? What needs to be provided and engaged on?
So I know that one of the first speakers, Maureen, from the first panel, talked a lot about people-centered care, and that goes for treatment and prevention. But in terms of all of the missing opportunities, these should be grabbed. You know, I mentioned the HIV testing and community testing, but also, you know, PEPFAR is putting quite a lot of money in terms of rolling out PrEP. And so there's this effort to find the negatives, and they will find people who are HIV positive who have never been started on TPT. If we are going to bend the curves in terms of HIV and TB mortality and incidence, then we have some other curves to bend as well. And one is cost, and I spoke a little bit about that. The other is complexity, and hopefully 1HP will make the provision of care less complex, so that as these HIV testing platforms, as the PrEP platform continue to build, we should be able to add 1HP as part of that. WHO is convening an operational research agenda building, and I wonder, let's not wait for 10 years from now to have data or results or trying to do same-day initiation. Give someone a whole month. If 1HP is a month, put it in a box and give it same day, and let's see how we do with that. But also the other curve that we need to reduce is burden on people. So that means the fewer clinic visits. We've already had a lot of effect in terms of, for ARVs, giving 3-month refills, 6-month refills. For 1HP, you guys, I think we really have to pretend that we're gonna have to put lipstick on a pig. This is a pig that has been around for a long time, essentially, right? 1HP, that everyone has been able to ignore. Out-of-step report that we did with Stop TB Partnership, we looked at the policies in 29 countries. And everybody says they're doing TPT, but we know the reality, obviously, as everybody has presented. So as long as we have that no-do gap, and as long as there is an accountability, I don't think we're going to have a change. But you also know how excited people get about a new cool tool. So let's pretend that 1HP, if WHO ends up recommending it, is the hot, new, sexy kid on the block that needs to be in every clinic. But let's also be context specific. So I know we have the LTBI population that needs to be treated, but can we focus? And so if South Africa already represents 39% of people who have been started on TPT, can we have South Africa convene some of its neighbors and have them in a room with donors, and nobody leave the room until they commit to funding 100% for TPT provision with 1HP or 3HP, or at least stepping up with Q-tip. Because the cost of 3HP is not an excuse not to do it, at least Q-tip, for crying out loud, right? On that we can agree. And then the union's going to be at India, so you've already got the Indian government promising not only to end TB, but end it 5 years earlier than everybody else. So what are they going to do about TPT? And when are they going to do it? That's what I want to hear at the plenary at Union. So we need to continue to use these moments. So right now, couldn't we have had government representatives more from the region saying, I am going to do this, and so we can hold them into account? Because part of what is so, you know, if I was to channel Luchika, one, I would probably drop a few F-bombs. I'm not going to do that. And two, I would say, you know, it's all the same people talking to each other, and everyone has got the best interests in mind. So one, is Sanofi in the room? No. No? Sorry, I don't mean to typecast you just because you're in a suit. No. Okay, Sanofi is not in the room. Our NTP is in the room. HIV program manager is in the room. We have some people from the NTPs. But in terms of gatherings like this, so we don't just exchange the goodwill, but we also can extract some accountability. So let's look to Union for that, and look to some of the regional platforms that we have, that WHO convenes, that UNAIDS convenes. Thanks.
Great, thank you. Talking about innovation that's not innovation, but it would be innovation if we got it to everybody right away. I like dressing it up and making it the sexy new thing. It might not be the only sexy new thing we need. And so thinking a little bit more, whether it's technology or service delivery or other research and development needs, maybe I'll come back to Cordelia and Patrick. What are the priority research needs or questions or innovations that need to be answered that would really allow you to leapfrog your TPT and scale it up much more quickly? What's your wish list?
Like you said, innovations will become innovations when taken to scale. I think there's one thing we've been doing since time immemorial, and for me, and which we have actually tried to do in Uganda, is taking quality improvement collaboratives to scale. And our focus was every health facility should be able to provide TPT and pick up the low-hanging fruits that are the clients already on ART and just start to do the TPT. So quality improvement is one that needs to be invested in and taken to scale, because improving quality is not cheap. So it's one thing, I think, for me as an innovation that countries need to be doing. And we heard from South Africa today. We have some stories from Uganda as well, taking it to scale at a national level. Two is the differentiated service delivery models, and again, taking to scale and bringing in the whole context of IPT. But I think my interest for me would be to look at the research around that, which models are going to give us the highest completion rates, but also improve uptake for. So I know most countries are just starting to do this. In Uganda, we've already embarked on some operations research through our Sequin engagement, and we are basically going to be studying this as we implement DSD and TB in the context of IPT. We want to understand how those models or service delivery models are going to impact increased uptake as well as completion for IPT. The other area that I think is critical for us to learn from is really the voices from the PLHIVs. And I was impressed by the Zimbabwe presentation today. But in terms of research, because I think he mentioned what are the myths around IPT in the community. So having the voices, the champions of people that have actually completed, have been engaged in this, tell their stories, listening from them, and really to address the key enhancers, what enhances IPT uptake, for me is something that we would want to listen to as we try to scale up IPT in the different countries. I think majorly I would want to hear from those in terms of research as well as, and then pharmacovigilance. I was particularly struck by the pediatric research agenda, and in Uganda, I actually wanted to just talk about it. Already, IPT for children is poor, the uptake is poor, but there are all these questions around, are we giving the right dose? Should we be reducing the doses? Should we be... So I think more work needs to be done around pediatric and adolescent IPT or TB preventive therapy, so that we are better able to understand how this can actually happen in terms of uptake, but also the monitoring. And then pharmacovigilance as a whole area around the scaling up of IPT. I think we've not done enough work around that.
How about you, Patrick? What's your wish list?
Yeah, so for me, I think my first wish list is to actually utilize what is already in existence. I think there are a lot of studies that are quite informative, but I think we have not utilized these informative studies to a large scale. So I think the first step, I think, is to inform most clinicians, most policymakers about the existing studies that are there. So let's utilize what is already available. I think now the second on my wish list is the issues to look into TPT completion rates. TPT is only effective when it's completed. So we need to bring in innovations that look at, does latent TB screening really, really improve completion without creating barriers? So we need to look at models that bring in the aspect of one knowing their latent TB status without creating a barrier in terms of TPT, patients being on TB preventive. I think that would be quite cardinal. And also I think more work needs to go into shorter regimens of TPT. Already, I think evidence is showing that longer regimens, patients adhere poorly. So if we can have more effective regimens that I think then that will improve adherence to TPT.
Great, thanks. I'm going to go to Wim, and then I'm going to go to Sharonann. So we've heard now 4 in a row talks about investments. Wim mentioned, the shrinking space and the lack of investment in civil society. Sharonann mentioned investment to fully fund 1HP. I think, Cordelia, you mentioned investment in quality. And Patrick, you mentioned investments in new combinations, shorter duration. So Wim, here's the thing. When we talk about pharma and new innovations from pharma, how can we drive investments in TB preventive therapy? I mean, this doesn't seem to be as sexy to pharma as a new hypertensive or anti-cholesterol medication. So I know you have some ideas on this. What are your thoughts?
So, given that TB is a disease that is happening mostly in low and middle income countries and far away from the high income lucrative markets, it's going to be, we're not going to see the gold rush like we saw for hepatitis C. Obviously, the traditional originator companies are not going to be that interested because their model, which needs to support high salaries, pressure from shareholders, is not going to be adapted for the public health needs. We need massive production of TPT. You would say, okay, there's a huge market, 2 billion, 1 billion market. There is potentially, but so we need massive production, and the fact of the matter is we're going to push for the lowest cost of that. We're going to push for generic manufacturing. So I understand that they're a bit hesitant to go into that area. They are patenting certain TB drugs for some indications that are happening in high-income countries, and that could be lucrative, but that's not going to be the panacea. So one thing is looking at alternative models of R&D, like delinkage, but it's slowly moving forward. And in the meantime, we can now pressure our governments to increase public funding quickly. And I think that's probably the fastest way of finding the funds for R&D, and especially then G20 countries, the high burden countries, the BRICS countries again. Advocates are calling for at least 0.1% of what a country spends on R&D to be dedicated to TB funding. That would already do the trick. That would already push the boundaries a lot further. It is happening with the BRICS TB research network, so it is starting, surely but slowly. only thing I would say is that it needs more inclusion from civil society partners in that network. It's very government-driven and academic-driven. There's one civil society person that fought themselves in there, but with the BRICS countries and civil society, we know how difficult that is. So we're back at square one.
Great, thanks. Sharonann's been dying to talk about R&D needs and barriers.
Well, just in terms of what Susan presented on earlier, the long-acting formulations. So we could all look forward to a day when there's perhaps something, a patch that you can wear. It's been a dream. Obviously, a lot more investment on the HIV space, but it was interesting to hear of some of the work being done that hopefully could reduce the pill burden even more for people living with HIV. But I also want to ask if we shouldn't be, I'm going to go off on a tangent, do you mind?
No,
if we shouldn't be more innovative, perhaps the International AIDS Society could reject any abstracts on ART cohorts if they don't also present on, for retention, for retention, for loss to follow-up, if they don't also present on TPT outcomes. The Global Fund should reject any proposal for funding for ARVs that doesn't already have documentation of what the government is funding or the funding to government to pay for TPT. We can't have ARVs anymore without TPT. We thought we could bend those curves with ARVs alone. Stephen Lawn tried telling us we can't, and now we have to adhere to the Stephen Lawn principle. We need both of them together. The other aspect I want to raise is just in terms of prisons. So IAS, union, they should reject any abstract, including from MSF. You have my permission. If we ever present on an abstract that is about prisons where we say, we gave ARVs and here are the outcomes, it should be rejected if we don't also present on TPT, if we don't also prevent on PEP for people who don't have HIV, and if we also don't present on Hep C treatment, frankly. But we need a prison project. And again, UNAIDS to convene some of the countries, start in ICA, talk to the minister, the person in charge of health in Azerbaijan, who has tried to do incredible things for HIV and TB, both on treatment and prophylaxis. Thanks. So we need some muscle in this little movement of ours.
Great. Let's come back over here to Vindi. And I think building on a little bit of what Cordelia mentioned on her wish list, expansion of both quality and also differentiated service delivery. Vindi, I know you've been working on quality of care for HIV services and DSD. So what kind of lessons do you want to share on that? And how could DSD for TB and TB preventive therapy be a game changer?
Yeah, so two aspects of the two questions, I'll answer them separately. On lessons learned from HIV programs and ensuring quality of care, WHO just put out a brief, a quality brief on sustaining and improving quality in HIV clinical services that pulls together a lot of guidance that WHO has put out this year and in the past, and builds on the Lancet Commission and the UNHLM-UHC, that meeting that is coming up, to really highlight the health system's approach to ensuring quality oversight, quality management, including quality planning, quality assurance, quality improvement within programs. So what that means for HIV programs is within the HIV program, systems need to be in place with supervision. And I think a lot of countries, the country program leads here will nod and say, yes, I have not been to a country yet. There isn't some form of supervision and effort to monitor the quality of the service to varying extents of success and so on. But we know that this requires a real national commitment. Mozambique, for example, has a dedicated person to quality improvement within the HIV program. They have a dedicated program that he monitors, a tool, assessment tool that's used for baseline and then for follow-up, improvement, et cetera. and he reports to the HIV program manager, and there's some level of accountability, et cetera, to that process. I think Zambia has a program, Malawi has a program, so many countries do. But we need to continue to strengthen these programs. They're starting, and they need a lot of support. And we talk about a culture change, a quality revolution, a call to action for quality. Very easy words to say, really hard to do. As we know, you go down to these resourced rural settings with overworked nurses and lack of stocks and et cetera. It's hard to deliver the quality of service you could deliver if you had everything there in front of you. So lessons for TB are let's integrate, let's build these systems together, because we know from studies in, I'll give one example, in studies in TB diagnosis in people with HIV, that there is not fidelity to the screening algorithm as we would like. The word fidelity becomes very important when we talk about quality. And there was a study from Lungu district in KwaZulu-Natal of 8 ART sites where 1,000 charts were reviewed, and of all the patients that were symptom screen positive, where somebody marked the box in the file that yes, they had TB symptom, only 20% had a gene expert test result in the file in a country where it was available, in a country where there was an electronic system, information system existing as well, and NHLS, et cetera. So I think we should jump on the UHC bandwagon and think innovatively within the countries how to build on each other's successes.
Thanks. And Sharonann, I wasn't glossing over your call to raise the bar and to really be able to lay bare where we're missing the boat and what are the different levers we have to close that gap and to really make people conscious and required to address these things more often. Honestly, and you mentioned prisons. How long have we listed prisons as a key population within the HIV community, within the TB community, and I think in every collection of rights and the right to health, whether it's for TB, for HIV, being incarcerated and not having access to the health care you need, not acceptable. I was actually, I think for the first time, in a prison about 3 weeks ago, that in a country I've spent tons of time in before, but as a US government employee, as a private sector employee, I was not welcome into the prisons. As a UN representative, I was. And it just sort of made it stark relief. Overcrowding, a prison system that does not cross over with the health system in terms of budgets or leadership or sharing tools. 17,000 people nationwide incarcerated, 5,000 estimated to be HIV positive, less than 28% treatment coverage for HIV, and broken everything. So I think, how we use our specific niche, how UNAIDS uses our specific niche to convene over people and communities and populations that are often left behind. I'm committed to figuring out how we do this. And in a shameless plug, UNAIDS, we launched the Global AIDS Update report last week with all the countries' data, and it showed about 53% of new HIV infections worldwide are now among key populations. So 53% among key populations. So for this panel, maybe, when it comes to TB preventive therapy, what will it take for us to reach those most left behind for TPT? Whether they're prisoners, whether they're children, whether they are MSM or sex workers, how are you proposing we really put the spotlight on the people hardest or that we've been least successful in reaching to date? Maybe we can just go down the line. We can start with Sharonann and work our way this way.
Well, can I suggest a bit of a rethink, which is to think about infectious disease and these key populations. So pregnant women universal expert, if negative, then PrEP. I mean, in terms of, let's get specific and not just about one intervention. And that for each of the major infectious disease that we're looking at, we look at the population as a measure of our success. We should always use the most marginal, the most vulnerable. Children for HIV, prisoners for TB, people who use drugs for Hep C. And so in prisons, if we don't have that package of care for HIV, TB, and Hep C, then we're allowing a crucible of disease. And I think having a session at Union, if Union and UNAIDS can do it, to have the ministers of justice there, because the health systems in prisons are run separately. They are run separately, and oftentimes might have to negotiate drug prices, and especially that's why we see such a gap on Hep C separately. For adolescents, if we could just start, at least in South Africa, if you've ever seen, the data on TB in high schools, for crying out loud. I mean, this is where, again, if in high schools you have the HIV self-testing rolled out, why aren't we doing TB testing just as well? If we could just get some of the PEPFAR recipients interested and have Ambassador Birx put her foot down in terms of these infectious diseases which will not be separated in the key populations that are affected, then that would go a long way.
Low-hanging fruit. Now, I was going to say probably the opposite. The last mile first. I mean, if in the universal healthcare model, if we make sure that we take care of the most marginalized, the weakest in our system, if we make sure that the model works for them, then it's going to work for everybody. So we know that the most marginalized populations, the prisoners, the people who use drugs, sex workers, men who have sex with men, I can go on and on and on. I don't want to forget anybody, but those, if the healthcare systems work in TB, HIV, or whatever, if it works for them, then it will work for the general population as well. So think of the last mile first, not the lowest hanging fruit.
That's what I said. You measure success by
Yeah. So for me, I think I agree with the earlier speakers about the models that should be used to reach everyone. I think one of the things that we need to do to reach everyone is to integrate TPT in every service point, be it in MCH, be it in ART, be it in the TB side. So at every point of care where this key population interfaces with the healthcare system, we need to integrate TPT in every service delivery model. That way we will enhance TPT uptake. I just also want to include another population of interest. I think if you look at the part of the country, the world I come from, southern part of Africa, there are a lot of mining activities, and miners are 3-4 times at risk of contracting TB. So I think in some of the opportunities that are existing are areas of occupational health. So TPT, I would like to suggest that TPT be included in those service points where we interface with at-risk population. Lastly, I think the other thing that we need to do is to actually create demand. I just want to share with you the experience I've had sitting in the clinic, in ART clinic, seeing people living with HIV. There have been moments where we've forgotten to add the time of Septrin. At the time we would forget to add cotrimoxazole. A patient would actually walk back to say, doctor, you forgot to add my cotrimoxazole. And I think it's because we created demand from individual perspective. That's why I think people are able to remind us of them as prescribing cotrimoxazole. So I think we need to reach that point where the public and everyone is aware that this is the protective effect, this is the importance of TPT. So essentially, we need to create demand for us to reach out all the key populations, and thank you.
So I think most of it has really been said, and I just wanted to add, strengthening our differentiation of services is going to be very key, with a focus on using peers as our champions to reach those populations that have been left out. The second bit is taking a deeper dive into our data, but not only that, but using it as programs to influence how we do our policy and guidelines to be able to reach those particular left out groups. And then they talked about the integration of services as well, which is very key. And the HIV mainstreaming into all the other sectors, I think, has been left behind. And you find that while it's just on policy and in paper, the actual implementation is not happening. So you go to sectors, like she mentioned, the prisons are different, the police, and so that HIV mainstreaming and HIV-TB together, as he mentioned, should be strengthened so that we are able to have better programming in those left-out populations.
Great, thank you. One thing that we've been discussing recently is the difference in trends in TB incidence and TB mortality across the regions. And actually, UNAIDS put out a report in March, and we've got a poster here as well on this issue. And we know that in certain regions, TB incidence and mortality in people with HIV is going up rather than down. So what's wrong there? Actually, a lot of it matches to broader HIV services and marginalized populations and HIV epidemics that are in populations that are either there's some policy barriers and human rights barriers to reaching folks, and the demand side factors as well. Those marginalized people have not been identified and not been identified with HIV, so they've not been offered TPT and also not been offered ART. So I think, you know, it's part of the key population strategy, trying to scale up TPT in that and increase access in those populations. But also, I think from a country perspective, I know in various country NSPs, I've seen a focus on looking at where the high-risk groups are and hotspots and populations that are of concern, like minors, et cetera, and trying to have more targeted approaches to reach those populations, and like some of the sex worker programs that we've seen in South Africa, et cetera. So there are a lot of opportunities as well to reach these populations, and we know what to do. There's a lot of experience in reaching these populations, and we know what the barriers are. It's just getting it, you know, doing what needs to be done. So I feel hopeful that if we can look at a country level at the epidemic and target the right places and the right people, we can bend that curve and reduce mortality there.
Thank you. Thanks, everybody. I was asked by the organizers to sort of tamp this down a little bit in terms of time, because everybody's had their dedicated day here. So I have a couple of questions for people, and we'll wrap it up and get on to the last session. People have shown an immense dedication being here all day. I'm gonna just quickly ask a show of hands of people in this room, how many are staying for the rest of the week for the full HIV conference? Raise your hand. All right, good. So just sort of building on, there's opportunities for some real peer influence as we go into other sessions and other topics, to be as simple as, what about TB preventive treatment? And queuing up for that. So I'd let you all think about how you can influence your peers throughout the program this week in terms of really changing the dialogue a little bit and raising expectations. I think I saw maybe 2 burning questions of people raising their hand really quickly. We'll go 1 and 2 for the panel, and then we will be able to wrap up. All right, thanks. The man in the black jacket right here.
Yeah, thank you very much. That was a very good discussion. I feel like in order to meet this global target, one very important issue to address is data reporting, our M&E system. And somehow, with the PEFA pivot, it looks like investment into M&E systems has been, it's not a priority. So I'm just wondering, is that something that Global Fund can support largely? I know like Eswatini has been trying to scale up the client management information system, which is like everybody has high hopes in that system, but for the past 5 years, they haven't really taken it far. So in the morning, I think Andrea Howard mentioned the fact that when it comes to M&E, the providers have preference for integrated M&E tools for TB, HIV, and ART. But then also, Sean Kavanaugh mentioned that with the PEFA push to scale up TPT, it's going to come with, I think, a standalone TPT register. So my question to Cordelia and or Patrick is how do you see, what do you think about these two options, integrated registers versus a standalone TPT register? Sharonann mentioned that Eswatini had 1% TPT coverage, and they were not very happy with that. And when they went back, they realized that the challenge was with the M&E tools. They have like 3 different places where TPT is recorded, and yet there is only one source for reporting, and these 3 are not matching. So, thank you.
Great, thank you. Let's take David's question as well, and then we'll go ahead and get responses and last words from our panelists.
Oh, thanks very much. Yeah, David Brodden with Results. I just wanted to know if we could zero in a little bit more on the need for accountability and activism for demand creation, for holding government officials accountable. Where is the funding that we need for civil society groups at national level to do that kind of work? I wonder if there's any critical assessment you could give of what is Robert Carr doing? What is the Gates Foundation doing? Rockefeller, other sources of funds. I know the Global Fund puts some money in. Thank goodness Unitate is putting some money into this Impact for TB. This is all good, but what's the landscape and who needs to do more? Because I feel like we can't succeed on demand creation and reaching these goals unless there's really a lot more funding for civil society groups to do the kind of things that our colleagues from Zambia and Uganda were talking about of hey, this treatment literacy for TPT.
And let people answer the 2 questions.
Okay, I think I'll start with the one on really about data, the information systems, and what tools that have to be used, and probably give just my experience from Uganda. I think it's something that needs to be discussed, and again, those were some of the contentious issues between the TB program and the AIDS control program. And one would say we need an IPT register. Just one should be enough, and the tools in the HIV clinic should suffice really to collect proper data on IPT. The problem was that not only IPT is not only for the positives, and that's where the biggest issue arose from. So you find that they needed to create a separate IPT register to collect that data at different points, depending on where the recipients of it are actually found. But having said that, in Uganda, our data management for IPT has been fully integrated into the HIV clinics, right from the patient card, and health workers are supported to actually do the proper screening and documentation for IPT. And this can also be found in the ART register, so that data can actually be found. The problem is that there has to be transcription into an IPT register. So it's something that is still, I don't think I have an answer to that, but it's something that's still being discussed because of the nature of the whole situation. IPTs for two different populations. And so I think for the meantime, it might have to be collected as such, and that will also create the difficulties we see in actually being able to report on IPT at national level. But we can hear from Zambia.
Thank you very much for that question. I think the experience of Uganda is similar to Zambia. I also just want to say that we both need the integrated registers as well as the standalone. I'll start with why we need a standalone register. I think my colleague has earlier alluded to it, that TPT is not only for the people living with HIV, but for other risk populations as well. I think it is for that reason that TP standalone register may be needed. But I think from the arm side of people living with HIV, I think we will need to integrate the existing tools, unlike having a different register, and that way it will be easy to administer. I just also want to share the Zambian perspective of how we have addressed this issue. From the HIV side, what we have done is to incorporate TPT into the electronic data collecting tools, which we call Smart Care. And this is how we hope to address the issues of the gaps with regard to TPT. So in essence, on the HIV side, TPT has been taken up in the HIV electronic data register. But I think for TB, for other risk population, we need to collect information. So a standalone register will be needed for that risk population. Thank you.
Thanks. And then briefly, because I'm getting the nod from the organizers, on not a brief question, but WIM, resource mobilization for community engagement.
Yeah, good luck. No, I can't speak obviously for Robert Carr or Gates or Rockefeller. I wish there were more funders available, and there are not that many. I can only say that from our part, the civil society delegations on the board of UNITAID, both NGOs and communities, that for years we've been advocating for systematic inclusion of civil society engagement plans within the grants. So whenever you start writing a grant, there must be meaningful involvement of civil society for a couple of reasons. Obviously because they can help with the demand creation as the project transits from, let's say, the catalytic funding of UNITAID to domestic resources or global funding. So civil society can really help with the scalability of these interventions, the durability and sustainability of it. And I'm not just talking about international NGOs based in the global north who should be involved in this or who should manage this, but we should definitely also involve the local grassroots organizations on the ground who probably have a better contact with local ministries and others. So, but I think that UNITAID is starting to do a good job in that resource for civil society, but I don't know about other funders really, and I wish there were a lot more.
Great, thanks. Okay, Sharonann, last contribution.
So if I wasn't working for MSF right now, I would ask Georgetown University to see PEPFAR recipients, what percentage of people that they put on ARVs have been on TPT and MSF. If I was not working for MSF right now, and if I was an activist in solidarity with my national colleagues, I would ask for INGOs that are working in the South to pay an expat tax, to pay a 10% tithe to national activist groups. Because without them, we would be nowhere in terms of implementation. So we can't have one without the other. Thanks.
Well, then I think maybe just to add a little bit on that, I mean, I think we are really concerned by the shrinking space for civil society, and by shrinking space, I mean funding, and particularly the funding for organizations in HIV or elsewhere, not just to do direct service delivery, but to be funded so that you can be at the table for advocacy, to be able to do that community monitoring and quality and feedback loop so that folks at national level know what's really happening on the clinic on the ground. to be willing to do the demand creation because you can actually vouch for the quality of the services you're trying to create demand for. And I think our report this year was communities at the center. I think one of the things that we noticed for the HIV response is we have nearly $1 billion less that was put out to the HIV response over the past year, which is worrisome. So I think it's not a bad note for me to end on saying this is Global Fund replenishment year. And getting a full replenishment will allow the Global Fund to do more of this funding. And I think certainly UNAIDS and other partners are not shy at the Global Fund board level saying this is a really critical space. So that's the second advocacy request. Tell your governments, fully fund the Global Fund replenishment, and then we can hold the feet on that to make sure more of that's going to civil society as well. So thank you, everybody, and let's thank our panelists.